Well, hello and welcome to another Sunday morning coffee with Dr. Childress here. So, today I'm going to be discussing the report format in clinical psychology. I'll compare it a little bit to the report format in forensic psychology. There are two different things, and they do. The forensic psychologists, the custody evaluators, have left the world of standard healthcare, standard clinical psychology, and they're just making up their own approach. So I will be today grounding us in what a clinical report out of clinical psychology, what that looks like and what the structure, basically to educate parents, is what they should expect, or the courts, what you should be getting from the psychologists and what it should look like. And also, though, this is if you're a student learning clinical psychology, this is what your report should look like. Um, and so, to begin with, in clinical psychology, I just want to point out that I've actually taught this at the graduate level. It was at University of Phoenix, their brick and mortar um, classrooms in Pasadena and San Bernardino. And I've taught this course in assessment and diagnosis. And so one of the things I'll be doing is just pulling up some of my slides from that course. This is from Jones in 2010, the Unstructured Clinical Interview in the Journal of Counseling and Development. And so this was the article, Jones, that I used to teach the students, the graduate students, the various structural format of a clinical interview, and then that becomes the clinical report. Jones talks about the clinical interview, not the report, but it's you just take the interview and structure it up into the report. And so to begin with here, just on what the clinical report, this is what your report should look like every single time. It starts with the referral question, and that's the sometimes it's called identifying information, sometimes it's called the presenting problem. But that's your first section: presenting problem, referral question, and identifying information. The second section, right after that, and the referral question should be about 2 to 4 sentences long, no more than 4 sentences, and it should summarize the situation and then or what we're coming into. Then the family history section follows next, and that's going to cover current family situation and family of origin situations. And typically you cover you start with one or the other. You either start with the current family or start with a family of origin, and that basically your choice, dependent upon what the issues are. Is a family of origin more relevant, or is the current family more relevant? And then you go into other histories as relevant: academic history, occupational history, social history, medical history, legal history, on and on. Then the mental status exam is the next section. And typically that's just sort of a general description of how the person presented. Sometimes with psychiatric disorders, that becomes more involved. Typically with psychiatric or disorders, that becomes more involved. Bipolar disorder, you'd be looking at the rate of speech, those kinds of things. Cognitive delays, you'd be looking at various things. Dementia, you'd be looking at various things. Persecutory delusions, you would be looking at various things in the mental status exam. And then once that section's done, and typically that's about 2 paragraphs long. And then you go into the summary and conclusions. And that's you're drawing forth from the history section to sort of just put it all together and describe it for everybody. And typically, most people who are reading a report will skip the earlier parts and go to the summary and conclusions. So that's where you really want to tell the story of what's happened here. And that story, that narrative, that construction in the summary and conclusions should lead right into the next section of diagnosis, so that when you offer your DSM-5 and ICD-11 diagnosis, it makes total sense based on both the history information and then that information is summarized in the summary and conclusion section. So it should all flow in a logical process from the referral question to what the histories are, to the mental status exam, into the conclusions leading to ultimately the diagnosis. And then based on the diagnosis, you will then make your recommendations as to what to do about that. So that's the clinical format for a report every time. So for example, if I'm called up on a psych consult at Children's Hospital, and so I go up to the cancer unit and I talk with the kid, by bedside, about something going on with the treatment. And then after I talk with the kid or talk with the family, I'll go back to my office and dictate into, into my phone. And got transcribed and came back, but I would dictate the report like this, a formal report that would then be placed in the child's medical record for all the doctors and everybody to see. When they ask for a psych consult, I provide my report about what's going on, and it's always in the same format. And that's what I do. Now, in addition, this is the format that I use in writing my consultation reports for the court. Okay. Now, with this particular format in my current consultation reports, it's the history section that gets a little bit more expansive because of the nature of the pathology here. And then really where I tend to expand the section more is on the summary and conclusion section, where I apply a lot of knowledge to the information that's reported in the family history section. But basically, you'll see this, and I don't do a mental status exam because I didn't meet with anybody, but you'll see this format in my reports. There's another type of format for writing for research articles, which is introduction, method section, procedures, subjects, procedures, results section, discussion section. That's different for journal writing. This is for clinical, anything clinical. So let's talk about each one of these sections for a second, starting with the referral question, identifying information, presenting problem. Now, this section, in all clinical assessments, we test or we assess to a question. If you just tell me, what's going on with my child? Oh my goodness, I could be assessing that forever. I need a question. What do you want answered? Why is the child having difficulty with math? I can answer that. Why is the child acting up in the classroom, and what do we do about it? I can answer that question. Does this person have bipolar disorder? I can answer that question. So I need a question to answer. What's your concern? Now, with that referral question, if you're an intern, let's say, and I'm supervising you, with that referral question, as your supervisor, you're going to send your report to me. I'm going to be reading it. And so what I want to know in that referral question is, what domain of pathology are we in? Depression, anxiety, child abuse, marital problems? What are we talking about in this situation? Because as I'm reading your history section, that helps me kind of organize the information. Oh, we're talking about possible ADHD. Then as I'm reading the history, I'll be pulling out information on ADHD. But if I don't know that, the information could pass by and I don't realize it's relevant to the issues until I get to the end. And so you start with a referral question that lets me know, why are we here? Why are we doing this? And I need about 4 sentences on that. Start with just the basic demographics. You start with the person's age, gender, marital status, ethnicity, just your basic, that's your first sentence. Miss Jones is a 25-year-old Caucasian woman married with 2 children. Okay, so there's your first sentence. She presented for treatment of depression, referred by her pediatrician or referred by her doctor. So now I got depression. Now with depression, though, on something like that, my first question, is there any suicidality? How severe is the depression? Do we have major depressive disorder? So the next sentence would be, no suicidal ideations reported, and then, is depressed 50% of the time, throughout the week. And so you present a little bit of the referral question to orient your reader, your supervisor, to what's going on. The second section that it'll go into, once you've oriented your reader, is the history section. And that almost always begins with the family history section. And so you want to talk about the current and family of origin, dependent mostly upon what the question is. Are we more focused on a current issue, or is the family of origin of significant relevance to the current issue? But that's a judgment call as to which family type situation, current or origin. However, you probably want to cover both, somewhere in that section to orient your reader as to what the context was developmentally, as well as for the person, as well as what the current situation is. Are they married? Do they have kids? Divorced? Those sorts of things. Then you go into your other histories as relevant. Academic history is relevant for children, so you go into that for children. For adults, not necessarily. So you may skip the academic section or just note it in a sentence and spend more time on the occupational history for the adult. Social history, if that's an issue, kids getting bullied at peers, I might break that out into a social history section around school, peer relationships, or if the adult has problems in social relationships, an avoidant personality, I might break out the social history section there. A medical history if it's relevant, legal history if it's relevant, substance abuse history if it's relevant, various things like that. So then you go into your other histories. So by that time, I should have a fairly complete description of what's going on there after the history section. And in that history section, if you are an intern or postdoc giving this to me for supervision and I'm reading that, I want to see, you're going to reach a diagnosis at some point. I want to see all the qualifying symptoms for that diagnosis in the history section. So when I reach the diagnosis, let's say of ADHD, and that's 6 of 9 of those symptoms, in your history section, I want to see the child was, bouncing around as if driven by a motor. The child refused to, sit down and, was climbing on things. Whatever the symptoms are for that diagnosis, for depression, the guilt, the child lost interest in activities, suicidality, all the depressive symptoms for a depressive episode, if that's going to be the diagnosis. I want to see all those in the history section. And because of the referral question, I know I'm looking for depression or anxiety or ADHD or oppositional defiant. And so as I'm reading your history section, I'm going, there it is, there it is, there it is. So by the time you reach your diagnosis, it's clear. So that's the history section. And then following the history section, I do a summary and conclusions. Now, for most reports, these summary and conclusions about a page long and 4 paragraphs. And it basically takes the relevant information from the history section, puts it all together, and provides a nice narrative description. If that's the only thing the person reads, they should have a good indication of what the family is. And again, as you're going through, when you're going to diagnose it, in the summary and conclusion section, note the symptoms that meet the criteria for the diagnosis. And so it's really clear that where your diagnosis is coming from. And then once you do your summary and conclusions, you reach your diagnosis, and that's just simply DSM-5 diagnosis. Now, there's 2 diagnostic systems, standard. DSM-5 from the American Psychiatric Association and the ICD-11 from the World Health Organization. America traditionally has used the DSM-5. The rest of the world has traditionally used the ICD-11. And initially, 1900s, they were a little bit different. But after 2000, they really worked on lining those up in the DSM-4. And then the DSM-5 came out and kind of misaligned a few things. So they're working to get those back aligned. But basically, they line up at this point as a walk. And the difference is the ICD-11 from the World Health Organization provides a code number for all medical and all psychiatric disorders. So it's used in billing for insurance billing. For medical and psychiatric issues, you put the ICD code down, and then they qualify that under the billing codes. So the ICD-11 is always used for billing. Now, the DSM, though, the ICD is just the code numbers. The DSM provides a more fulsome description of the pathology. They're going to pages about associated features and differential diagnoses and stuff. So the DSM-5 gives you better sort of overall description of the pathology, whereas ICD-11 gives you all the standard code numbers. So that's the difference. And in the diagnosis section, it's basically take your choice in America. Although for billing, it's going to be the ICD-11. And then finally, the recommendations based on the diagnosis. And so that's how diagnosis guides treatment. So if this is a treatment-related report, I'm going to have treatment-related recommendations. If this is a school-related report, I'm going to have recommendations for, remediating the learning disability, or recommendations for classroom behavior interventions, or those sorts of things. So my recommendations will be based on my diagnosis and the referral question. What question did you want answered? I will answer your question and provide you with recommendations about what to do about the situation. So that's the report format in clinical psychology for all reports. Now, here's the report format for forensic psychology, and it's entirely different, and it's entirely made up. They just made this up because they thought it was a good idea. Let's do it this way. It's not a good way at all. This is an awful, awful format for a variety of reasons. I'm willing to debate this with any forensic psychologist anytime. This is just awful. So the first part is they put a bunch of formal words out there, and that's just defining the scope of the assessment, that it's a forensic assessment. So about 5 or 6 pages, who they interviewed and confidentiality things, and just all the formal side of the paperwork. Now, that's mostly just cut and paste on this. Now, recognize, though, this is my opinions here, is from experience. I read these forensic custody reports over and over and over again as a second opinion review. So this is what they do. Okay, and this is from experience. So first is a cut and paste section, and then comes their verbatim reporting. And what they do is they audio record the interviews and just let the people talk. And so it's just basically a transcript of people just telling what their concerns are, and without any professional processing of information or without any direction from the psychologist or anything. They just let people talk and say, basically, what are your concerns? And then they go on for an hour and a half. And they get a transcript of that. And then this first section is reporting on the transcript. Now, I haven't confirmed that it's a transcript, but it has to be, because they're quoting people. Sometimes they get big block quotes and they just put block quotes in there. Most of the time they paraphrase, so it's just basically the transcript by paraphrasing. Now, I can get a high school student to audio record people talking and then present that as the transcript in a format. Okay, so there's no professional level activity occurring with this and it's a major part of their report. It's just, the mom and their interviews with mom, and mom, the interviews with dad, interviews with each kid. And so they have this whole thing, but it's just a verbatim transcript of an audio recording. And I don't know about attorneys, but if you want to see if there's an audio recording and transcript, you may want to request that. Get the transcript of the actual sessions if they have it. That would be very interesting to look at. And then you could verify whether or not they accurately reported on what was being said if you have the transcripts available. So that's the situation. But they basically, unless they have excellent memories, they basically report on what everybody says without any professional processing of the information in any way. And let me describe, that's way different than a clinical interview. So when you come into me for a clinical interview, I'm going through a bunch of differential diagnoses in the back of my head because you see my report. And so you say, I'm depressed. I'm going to go bipolar disorder. Suicidality pops up there, major depression, loss of a job, guilt, all sorts of features pop up there that I want to know about. And then I'll specifically ask you questions designed for my criteria. Okay. Have you ever felt like you've had a lot of energy? Okay. Where you've been up all night and been working on projects like that? There, I'm differentiating between depression and bipolar disorder. Have they had a manic feature? So I'm going to ask about manic symptoms to see if to rule that in or out. So I'm actively acquiring the information that I need to make my differential diagnoses. Now, the forensic psychologists do not do that because they're not doing that. They're not making a diagnosis differential or not anything. So they just let the person report. And they're not asking questions. They're not moving. They're not following up on anything. They're not discriminating in the information in any way. They're just letting the information flow on in, which is extremely bad. Again, I can get a high school student to do that. So then that's it. That's basically the report. Then they go into psych testing, and those are basically random instruments of no value. The MMPI is pretty common, doesn't typically show much, and it's not appropriate. And I don't know why you're doing it. If you want to do some assessment with these kids, do the Roberts apperception test for children. Okay, that'll give you good information on the children. But using the MMPI or these sorts of, it's just not relevant and not necessary for the differential diagnosis. I don't need to do psych testing. That doesn't add anything. And from a clinical perspective, I can get all the information I need from the clinical interviews. I don't need testing to answer the referral question: which parent is abusing the child? What's causing the child's attachment pathology? There's no tests for that. Okay, so testing is irrelevant. Then they do this home observation thing that is, again, immensely irrelevant. They just go into the home and watch the child and parent interact in an artificial setting with them there. And so with the alive parent, it's just presentation of how wonderful we all are getting along. And with the targeted parent, the child acts up. And I could tell you what you're going to observe before you went out there. In addition, you're not applying any criteria from any behavior observation system. So I read your observations and I say, wow, that's a really messed up relationship. And you say, oh, that's a really bonded relationship. I say, do you know what you just watched? That's horrible. That's awful. But you think it's healthy. Oh, my goodness. And so it's that type of bias that comes into it. And I'm not sure what you're trying to get from a home observation that you wouldn't get from an office observation. So when I do my assessments, I pull in the parent and the child, put them in my clinical office and watch them interact, talk with them, and poke them around, do response to interventions and stuff. And I see the symptoms displayed in my office, and I can work with them in my office to see what they look like. I just don't sit back and say, play a game of Uno with your kids for the next hour and let me watch. That's pretty irrelevant, but it's billable time. And what the forensic psychologist, what you'll see here is it's a hodgepodge. They were given permission somehow to just create their own assessment protocol here, whatever they want to do. And so they said, let's toss this in. Let's toss this in. Let's toss some psych testing in because it looks like it's technical and scientific. Let's toss some home observation in because that's a different way of gathering information. It's like awful. Made up stuff, just out of their own imaginings. Awful. Okay. So from start to bottom. So after the home observations, then they report on collaterals, and these are just summaries, not typically transcripts, and then so that's going to be subject to bias and stuff. But they don't necessarily use the collateral information, and it's of differing values. Some is the mom's friend, and others is mental health treatment providers and things. But they report on the collateral information. And because they like different sources of information, they think that makes it more reliable and more valid. No, it doesn't. They're just so stupid. So the collateral reporting, and then they go into their summary, and their summary is simply personal opinion, no diagnosis, nothing. No application of knowledge, nothing from attachment or family systems or delusional thought disorders or the DSM. Nothing, there's no professional level processing of the information. They just provide a personal opinion on what they think is going on because they think that's of value, and it's not. It's just your personal opinion. But they're got into the situation where everybody is doing this. And so that's what they do. And then they go into the court and give their personal opinion. It's awful. It is so bad. And then they offer recommendations that are, again, just personal opinions based on misdiagnoses and no diagnoses. And I don't know how the forensic custody evaluators can make recommendations to do something about the problem, about the pathology, if they haven't first identified what's causing the pathology, the problem. If they don't know what the cause is, how do they know how to fix it? Diagnosis, identifying the cause of the problem, guides treatment. The treatment for cancer is different than the treatment for diabetes. So are they treating cancer or diabetes? We have no idea what they're treating because they haven't diagnosed it at a professional level. I, as a doctor, should not have to guess what their professional level diagnosis of the problem is. Is there a shared delusion? If I have that question at the end of their 7-month assessment and 50-page report, and I still don't know if there's a persecutory delusion in the family, that is not acceptable. From an intern, I would pop, if an intern gave me a forensic custody report, I would pop it back so fast and just say, where are the symptoms? Tell me the symptoms. Put a diagnostic criteria next to that. Apply knowledge from family systems, DSM-5, trauma. I want to see professional processing of this information and an accurate diagnosis that is supported by your symptoms for an intern. And here I've got licensed psychologists practicing below the level that would be acceptable for a trainee. And they're going to send in these reports into the family courts. They're awful. So that's the situation regarding the thing. Now, I want to, again, just point out from Jones that these are my slides from the course when I taught this to students. And so Jones here, you start with the identifying information, and then you go into the history of the presenting problem, then family history, developmental history, education history, work history, medical history, substance abuse history, legal history. Okay. And so, and previous counseling. Okay. That's often kind of interesting, especially with borderlines. With the borderline, she'll come in, typically woman, she'll come in and say, my last therapist was horrible. Oh, they were awful. As opposed to you, you're wonderful. You understand me so well. And you get that splitting. The previous one was awful, and you're the wonderful. And if you're inexperienced working with borderline personality, you kind of inflate on that. I'm wonderful, and I'm so much better than that previous therapist. Until you have an empathic failure, and then all of a sudden you're the horrible therapist, and the next one is the all wonderful one. So the previous counseling. The other good question on previous counseling is, have you ever been in treatment for this before? And they say, yeah. And you say, did anything help? Was anything helpful? That's a useful question. Well, yeah, it helped when I do that. Oh, okay, let's start doing maybe more of that kind of stuff. So that's previous counseling kind of situation. Mental status exam. And typically mental status exam is not relevant for many things. It's just your basic description of the child within normal limits, within normal range is a frequent statement in a mental status exam. Thought processes are linear and logical and within normal range. Insight, is within normal range. Person is oriented, time 3, that kind of stuff. But for psychiatric issues, bipolar disorder, schizophrenia, delusions, depression, anxiety, kind of things, you'll get a more elaborate mental status exam, either on the emotion side, labile affect, it's all over the place, flat affect, it's just not moving anywhere, or for emotional kind of regulation issues. For cognitive issues, you're going to get linear logical reasoning, tangential thinking, circumstantiality, associational, free loose associations kind of stuff. So depending on the psychiatric pathology, you'll get different domains of mental status. Over here in the family courts, you guys should be doing a mental status exam of thought and perception. A sweep of the frontal lobes looking for a thought disorder, persecutory delusion. And the diagnosis of a persecutory thought disorder, of any delusion, is not made based on history. We pop the delusion right out in our session and take a look at it using the mental status exam of thought and perception. That's what it does. It sweeps the frontal lobe executive function systems for linear logical reasoning. And as it's sweeping them, if there's a thought disorder in there, it goes whoop, and pops it right out in the session. And then you can take a look at it. But it's really difficult to do. You have to be kind of trained in the assessment of a delusional thought disorder. Typically, that comes out of schizophrenia. And that's where I got my training, 12 years in schizophrenia, on how to do a mental status exam of thought and perception. So, at least to begin with here, as we transition back into clinical psychology, all the forensic people should be getting trained and should be getting consultation on the assessment of a delusional thought disorder with a mental status exam. And this should be a more fulsome description within the clinical assessment in the family courts. So with that, that's a description of the current report formats in the situation. The forensic psychologists have just simply made up a whole bunch of stuff, and that's awful. It is an experiment in this new assessment approach they made up. It is a failed experiment, and professional psychology in the family courts needs to return to clinical psychology, the application of knowledge, diagnosis, and treatment. Doctors do not decide on custody. In the absence of child abuse, parents have the right to parent according to their cultural values, their personal values, and their religious values. In the absence of child abuse, each parent should have as much time and involvement with the child as possible. And in the absence of child abuse, to restrict either parent's time and involvement with the child would damage the child's attachment bond to that parent, thereby harming the child and harming that parent, and doctors do no harm. So the only question relevant to the doctors, to a clinical assessment for their family courts, is there child abuse? And when you have a child rejecting a parent, a directional change, instead of wanting to bond to that parent, the child wants to flee that parent. When you have that symptom, the only cause is child abuse by one parent or the other. So you want to conduct a proper clinical diagnostic risk assessment. Is the targeted parent abusing the child in some way, creating the child's attachment pathology towards that parent, desire to flee that parent? Or is the allied parent psychologically abusing the child by creating this persecutory delusion and false, factitious attachment pathology imposed on the child for secondary gain to the allied parent? The secondary gain would be manipulating the court's decisions regarding child custody, spousal abuse of the targeted parent using the child as a weapon, and as a regulatory object to meet the allied pathological parent's own emotional and psychological needs. So you have two differential diagnoses, child abuse one way or the other. We need to get a proper risk assessment for child abuse to inform the court for its decision-making regarding the child. And we need to do this consistently, routinely. A clinical diagnostic assessment with a report like I showed you can be returned within 4 to 6 weeks for around $5,000 with a second opinion consult on it through telehealth. And that we should always be getting second opinions because it's going to be a disputed diagnosis in the legal system. That's just the way the legal system is, adversarial. You put a diagnosis in there, one side or the other is going to dispute it. And the appellate system for a disputed diagnosis is second opinion. So let's get the second opinion right at the start, third opinion even. Each party can appoint a second opinion consultant to the assessment. We get 3 opinions from 3 doctors. I guarantee you will get an accurate diagnosis. And if there's a little discrepancies, the judge can decide which doctors he believes are more accurate and go with the opinions that seem more reasonable and grounded. Okay, that's a judge's decision. Well, let's get the judge good information on which to make those decisions. All the time, 100% of the time. And we can do that when there's the motivation to do that. However, currently, all the forensic psychologists are motivated to not do that because the moment they start, they admit they haven't been doing that. They haven't been protecting the children. They've been misdiagnosing the pathology, and they're not competent in the clinical diagnostic assessment of the pathology. So they're all going to have to leave because the only thing they do is these bizarre, awful forensic custody evaluations. And so they're going to go away. They're out of the family courts. And we're going to get good psychologists into the family courts. But the bad psychologists don't want to go away because that's how they're making their car payment, the house payment, and all that stuff. They're big hotshots in forensic psychology. They don't want to leave the field, but they're going to the moment we switch to clinical diagnostic. So right now, there's a tremendous conflict of interest within the AFCC and the forensic psychologists who are essentially disabling the mental health system response of diagnosis and treatment because they don't believe in it. They think they do something special that's better. And that's not. It's awful. And failure and duty to protect, incompetence issues, violations of ethical standards, all over the place. So that's where we stand right now. Conflict of interest with the forensic psychologists. We need to return to clinical diagnostic assessments. The moment we do, 4 to 6 sessions, we can get the court a diagnosis of whether there's child abuse in the family and by which parent. And that's the scope and limit, typically, of a clinical involvement. Courts make decisions on custody, not doctors. In the absence of child abuse, each parent should have as much time and involvement with the child as possible. And they have the right to parent according to cultural values, personal values, religious values. So the only question is there child abuse and by which parent? So with that, good luck to everybody out there. And I'll check in next week about some other aspect of this family court pathology.